Hello and welcome to the 2017 CPT Changes Update. My name is Maria Bunos and I'm the Practice Lead for Coding and Reimbursement here at Wolters Kluwer. Joining me is my colleague Raylan Kishbaugh. Raylan is the Manager for Customer Success and Product Development. Before we begin today's webinar, I wanted to let everyone know that you can place questions in the Q&A panel to the right of the screen. Please, last time we did this particular webinar, there are a lot of slides, so we didn't have a whole lot of time for a Q&A session. So please keep the questions within the scope of today's presentation. There are handouts associated with today's presentation as well. Those also can be loaded, found, and downloaded to the right of your screen under handouts. And lastly, there are CEUs associated with today's webinar. We have placed our application, however, we have not received the receipt of those CEUs from AHIMA and AAPC. So please note that if you are a registered attendee, once we receive those CEUs, we will send a survey out to you. Please complete the survey. We always want to know how to better serve you in 2017, and then you can download those CEUs. Now it is my pleasure to introduce to you today's speaker. Today's speaker is Gail Smith, and Gail is the president of Gail Smith Consulting. She is a healthcare consultant for more than 30 years in the industry. She is an author. She's authored several coding publications, including AHIMA's Basic Current Procedural Terminology and HCPCS Coding. She holds a master's degree in education from the College of Mount St. Joseph and a Bachelor of Science degree in Health Information Administration from The Ohio State University. She is a registered Health Information Administrator and a certified coding specialist for physicians. Without further ado, it is my pleasure to introduce to you Gail Smith. Gail?
Thank you, Maria. It's my pleasure to be here today. And for our time together, you should have an agenda in front of you there. I will be presenting some key changes you can expect for CPT in 2017. What I've discovered, I'm going to pass on some coding decision drivers, which is essentially documentation, here we go, documentation pieces you'll be looking for that will impact your coding selection. And to add meaning to the codes, I'm a firm believer in anatomical drawings, and I think most learners are, descriptions of how surgical procedures are performed. I used to tell my students when I was in the classroom, don't code what you don't understand, because it will embarrass you every time. So that kind of leads my presentation is let's discover what these codes are all about from the anatomical standpoint as well as what surgical procedures drive the decisions. Now, what you're going to see in today's presentation are 5 polling questions. That's for me to work with you so I can see what you're doing out there. They're check your knowledge kind of questions, and my buddy Mary will launch those for us. And to get the most out of this webinar, I think you should have your code book in front of you. Hopefully you have the 2017 version. If not, we'll muddle our way through. First, some overarching changes. The first section of the presentation is about what the global changes are in CPT this year. And the rationale for most of the changes this year, it seems to cluster around, well, AMA says we had committees look at the data, there was inconsistencies on the use of the codes, or there was changes to medical practice, or that the codes seem to be undervalued for some of the procedures. Now, there's numerous, every year, there's numerous editorial or wording kind of tweak changes to make the nomenclature a little cleaner and improve the terminology. So I'm not going to focus on those today. I'm focusing on the Big Bang Theory. So let's start off talking about Big Bangs. What you see on your screen, the 2 green sideways arrows, is what you see in CPT when there's new notes. There seems to be a trend over the last 5 years that this has exploded. They're trying to give us more guidance. Now, you will not get those new notes from Appendix B. Remember, Appendix B is where all the new codes, changes, revised codes, deleted codes are kept. But these notes are so important to help you, guide you as a coding professional, so what you can and can't report together Sometimes they'll give you some instructions on what it means as far as the anatomical notation. And I don't have all these memorized. In fact, I repeat over and over again. I read the page, and then it's dog-eared in my CPT book right now. And that's where I think our software tools are going to help us sort through what you can code, what you can't code together. And we're going to have a demo today. Ray Allen's going to help us out towards the end of the presentation. And that fits nicely with the theme of you can't be an expert on everything in CPT. You need tools. First big change you're going to see is with moderate or conscious sedation. For those of you who had a chance to scan through Appendix B already, you're probably surprised at the volume of revised codes. At first I was startled, and then I calmed down and said, oh, most of these are changes due to the overarching change of moderate conscious sedation codes. You probably remember in the past, CPT started placing a bullseye symbol in front of codes that had bundled conscious sedation within the codes. So those little buckeye symbols told us, the providers as well as coding professionals, that you should not report a moderate conscious sedation with those CPT codes. In other words, the sedation was bundled. You saw those throughout the book, but mainly you saw them in the endoscopy section, such as colonoscopies, EGDs, those kind of things. And now they removed that symbol, and along with that, also they removed Appendix G, which is where the list of those codes have gone. So technically, you can report conscious sedation codes with any procedure. Well, let's look at conscious sedation on the next slide. They deleted the old conscious sedation codes in the back of the medicine chapter 99143. I won't read it to you, it's on this slide. And they created new ones. And what they've done, they've given detailed notes on the use of these, describes what kind of service needs to provide. It is time-based. And if you have a professional edition of the CPT book, you're going to see a table. They started using those tables years ago. It's very helpful. It outlines the decision-making criteria based on the patient's age and the intra-service time. And you'll see that it's increments of 15-minute periods. And the way that it's been described, as CPT reported that they needed to change these codes due to the change of practice of medicine. They said time needed to complete a procedure has decreased. Therefore, they wanted to reflect that in the codes. Lots and lots of details on the notes. So if this is something that your practice does, or those in the hospital, if this is something that you're in charge of, you're going to have to take the time to read those notes in detail on when you can use these codes and when you can't, and what kind of documentation supports the use of them. Another overarching change, this is kind of exciting, is the use of telemedicine. They've determined some of these, and I think I read somewhere that CMS has started to pay for telemedicine services, and that's probably, and that's me talking, that's not CPT or AMA. We now have a new symbol. It's a star that appears in front of certain procedure codes that are qualified for telemedicine services. Along with the star is a list of those codes. If you're wanting to know if they affect your practice, I would go to Appendix P, as in Paul there, and it has a list of all the codes that are applicable to have to be reported as a telemedicine service. In addition to this is a modifier 95, and if we look at on the screen here, I provided an example of a code 90791, psychiatric diagnostic evaluation. With that star, it tells us that that is applicable to be reported as a telemedicine service, but you're going to have to use modifier 95 on the end of that in order for it to be appropriately reported. Now be careful with the description. This isn't just a telephone call between a patient in another city or the convenience of a doctor in the same city. This is real audio, video, telecommunications kind of service, and it's outlined very clearly in CPT and what that means. It's getting lots of attention. It started in the military. They started doing telemedicine services in rural areas. So you'll see that most of the codes center around counseling, therapy, or asking a physician to analyze data from some sort of monitoring system that the patient's on. So I thought that was pretty interesting. We're going to shift gears now into the musculoskeletal system. And the musculoskeletal and the cardiovascular get my vote for the most changes this year. And we're going to look at those changes right now, starting with kind of a simple change. Oh, no, not yet. This is one of my themes. I have two major themes in the musculoskeletal system. One is it's all about anatomy. I see patterns of, and you'll see this in the presentation, that within the code is embedded more anatomy-based decision-making about the surgical procedures. And I think the best illustration is on this next slide. And if you have your code books open to 20240 and 20245, you're going to see some changes here, subtle changes. And the reason is they've given you some more anatomical descriptions of what falls into superficial versus what falls into the deep bone biopsy codes. And the way it was explained, AMA said that there was a committee that looked at the use of these codes, and they noticed that reporting of the deep bone biopsy, that's 20245, was being misused and misunderstood, and the documentation did not support it. And of course, I'm paraphrasing. So they added a little more oomph to the codes to help us differentiate between what is superficial and what is deep. You realize that the deep codes require more expertise on the part of the physician. It's more difficult to do. It's just more of a technical skill on the part of the physician to perform that. Okay, ready for our first quiz question. This is how it's going to work. I'm giving you a multiple choice question. You're going to see 4 choices. Don't be scared. Just pick your best guess. Let's see how this works. I love when they take over for me. Here's the first one. All of the following, except one of those, are superficial. So which one is a deep? Which one of those 4 anatomical designated bone biopsies? Now this is pretty much fun because I can see the group. Oh yeah, we got some early adopters and they're all getting it right. Okay, I'm watching the screen. We are close to 90% choosing option C for ischium, which they're right. The bones, the metatarsal in the foot bones, the carpals in the wrist, and the knee are all incorrect choices. And the way they described it, I heard one article I read that you can feel it. You can feel your bones in the wrist. It's not hard for the doctor to take a bone biopsy of the wrist, but the ischium, yeah, it's a deeper type of procedure. Great, this is good. Thank you for participating. 4% chose metatarsal, 2%, let me look back up here before I lose that. There we go. 2% chose carpals, 87% chose ischium, and then 7% chose patella. Good. Now let's move on. Still continuing with the theme about anatomy, you're going to see some changes with and I got the codes on here, I hate to read to you. It's starting with 27197. This is for closed treatment of posterior pelvic ring fractures, dislocations. You can look at those codes. It's a lot of descriptions there. But they deleted the codes we had last year and reworded it, and you'll see that the key change here is the differentiation between the posterior pelvic ring fracture treatment and anterior pelvic ring fracture. So let's see what that means anatomically. This is again, another anatomy lesson buried in these codes. As always with CPT, they'll differentiate in the musculoskeletal system between with manipulation, without manipulation. I chose this, actually purchased this diagram off of Shutterstock to show you the difference between the pelvic ring that's anterior versus posterior. Do you see the circles on your screen for ilium, sacroiliac joint, and sacrum? Those are all designated as posterior portions of the pelvic ring, where some of the ones you see there at the bottom of the screen, the the pelvic crest, the pelvic symphysis, the pelvic bones down there, the ischium, those are considered anterior. Now, if you look at the description of 27197, you'll see that we really don't care if anterior is mixed in there with the posterior. That's not the defining decision for coding. What is interesting is that if it's only an anterior pelvic ring fracture, you're guided to use an E&M code, so not a surgical code. So I think that was an interesting differentiation. So that's just one, another example of the importance of anatomy, using your illustrations such as this one to differentiate, and then read the operative note to see what the doctor's documentation says. The next theme I saw, and this has been going on for years, is about devices. Devices are ruling in the operating rooms in most of the places in the United States. And this is I love this drawing. If you look on the screen, because it's so vivid with a 3D image, those red pieces of the spine are considered the intervertebral discs. And we're going to talk about this. You can't understand these codes without going down that pathway. And those chunks of white between the red are vertebral bodies. If the doctor chooses to excise that, that's what they call corpectomy. And then muted on the left-hand side of the screen is the posterior part of the spine, and you'll see all those little nodules sticking out there, and that's the spinous processes. And you can feel that if you rub your hand down your spine. And what we're going to look at in a few seconds is the choices of the new codes we have for using devices in the spine. But first, I think an anatomy lesson, quick anatomy lesson is appropriate. This is a side view of the spine. The yellow pieces, so that cushiony kind of vertebral disc, looks healthy on this one. The white chunks on that's the anterior side to the left, is the vertebral bodies, and of course the yellow are the nerve roots, and then the other side sticking out are the spinous processes. The spinal cord is going down the middle, a little harder to see, but you can definitely see the roots coming off the side. When we talk about intervertebral bodies, we're talking about the anterior part of the spine. Let's look at another drawing that's very similar to the last one, not as pretty, but this helps you differentiate on this view the spinous process, as you see the little pointy parts on the right-hand side. And then that's the posterior spine. And the anterior, on the left-hand side of your screen, is where you see the intervertebral disc in the body. And I mentioned the corpectomy would be removing the body of the vertebrae. If they put in a device afterwards, then they're talking about right there, that body. Intervertebral disc, this is, it's blue on this slide here, is where that shock absorber that the spine needs. And the doctors often talk about interbody devices, and when they do, that's what they're talking about. They'll talk about putting cages in there. When they put those cages in, after they take out part of that, all or part of that disc, that's what generates the body to fuse. It's like, oh, but there has to be bone inside that cage. If there's no bone, then that's not fusion. More on this topic as we go through. So here's a picture of a cage, what it looks like when they put that right there in the anterior spine in their inner body. For fusion, again, I can't say this enough, there seems to be confusion in the industry, and we're constantly being asked when we're doing our PCS or CPT presentations is, well, they put a cage in, but they didn't fuse. Did they put bone in that cage? Yeah, then that's fusion. That bone material is what makes the fusion. Checked one time, I had a physician in the class, and he was talking, he says, yeah, without bone being in that cage, it's not going to fuse. That would be magic and not surgical intervention. So that stood out in my mind. Let's look at a corpectomy. And this is how, I think I got this one off the web, so thanks to somebody. That blue metal part is how they put in a device right there when they remove the body, the entire hunk there. That's an unofficial term. All right, now to the codes. You're saying, okay, Gail, you've talked enough about anatomy. How does this make a difference? Well, let's look at the 3 new add-on codes for interbody biomechanical devices. I think this is interesting. This is where engineering intersects with the medical world. Let's take a closer look at those. The first one, 22854, is an interbody with arthrodesis. So we have fusion. So they're inserting a device, and they list in the CPT descriptions, cages. I see peak cage used a lot in the documentation. So that's where it's an add-on code. So if you're doing fusion, obviously this would be in addition to your regular CPT spinal fusion codes. It's an add-on. All these are add-on. The next one is a corpectomy, and I'm giving you a description of what that looked like on the previous slide, 22854. So they're putting in a device after they take out that body, that white chunk of your spine. And then the last one, 22859. This one's really interesting. It says, okay, we're using an inner body device, but it's not for fusion. So you say, okay, wait a minute. Well, they're going to put something in there. They also use methacrylate. You know what it is. You can look it up in the code. It's kind of a cementing substance. And they refer to synthetic cages and meshes, and then they use that in that last code, 22859, that methyl methalicate. There you go. I came close there. This is less common. I've seen a couple cases where a patient has cancer. They are not fusing. They're just putting in the device to give the patient structure to the spine. This is a nice drawing, too. You'll see the blue shows on this illustration the inner body discs. That red is showing pain. They're trying to show that the patient's spine is being hurt or the nerve roots. Okay, we're still under the theme of devices, but we switched from the front of the patient, the anterior side, to the back side of the patient. So on your left-hand side of your screen, you can see an intervertebral disc and the vertebral bodies we already talked about when they put devices in there, and the biomedical devices on the previous screen. Now outlined in red on your slide is the lamina and spinal processes, and we're talking about inserting devices, stabilization and distraction devices, using codes 22867 to 22870. These are all new. This is not affiliated with fusion. The magic for fusion is not going to happen using devices by itself in the back. And then on the right-hand side, well, by the way, let me point out that the procedure might describe removing some of the lamina and facet joint for decompression. So you might see documentation of decompression. The bone is pushing on the nerve. And so what they do is they allow to separate those vertebral bodies with this device and still permit the patient to have motion. So it's a quality of life issue here. So on the right-hand side of the screen, I got this particular image from the manufacturer Coflex, and you'll see that written right there in the middle. And that's the device that they're putting in to provide stabilization there in the spinal processes, little hanging down parts. Now let's look at the decision makers for documentation for these codes. The decision making on this depends on if there was open decompression or not. So 22867 is with open, and then of course you can see the 969 code is without open decompression or fusion. The diagnosis you're going to see in this will probably bulging disc stenosis. There's some sort of relief that's needed for the patient because if there's pressure on the nerve roots or the spinal cord. And we saw that in a couple of diagrams. Be careful in this. There's an extensive list of exclude codes that are printed with the CPT codes. And also there's two additional codes for additional levels. So the codes also include imaging. That's one of the deciding factors here. But one of the things I want to point out to you is the last one. It bothered me when I first looked at this code, 22969. It says, without open decompression or fusion. And I'm thinking to myself, wait a minute. And you're probably saying the same thing. If you insert one of these devices for fusion, which one do I use? Well, remember on the previous slide, they don't do that for fusion. It's for stabilization and distraction. So the wording on this is a little misleading. I think I would have done it differently. But I don't want you to think the magic of fusion happens. Fusion's not with either one of these codes. Okay, one last summary slide before we leave the spine. just kind of to make sure that we're all on the same page. And I think when I first learned how to code spinal procedures, I was struggling because I didn't see in 3D. This is back before the internet. I can't tell you how valuable the internet has become to learning how to code spine surgeries. And I have a slide I added at the very end of the presentation on where I get a lot of my good visuals. First one's Blausen, B-L-A-U-S-E-N. There's a package you can buy for your iPad or iPhone. I'm not selling it. I'm not getting money out of it. I just love it to death. And it helped me solve my problems with the spine. It's free on the internet. They have some beautiful videos. Also free is Spine-Health. And again, I'll give you the exact description at the last slide. And that's a free one, very well done, very good imaging. And so that you can see that what we talked about first was on the anterior side of the body. That's the top of the picture. And then we just finished up with the stabilization distraction devices on the lamina or spinal stenosis. And without a good understanding of the anatomy of these procedures, we have problems. Okay. Now we're still in musculoskeletal. Remember I told you it gets my vote for the most changes. These changes were a surprise to me this year. The hallux rigidus and hallux valgus, the codes changed slightly, but if this is your area of expertise, then you're going to have to pay attention. If not, I always believe that transfer knowledge in CPT is invaluable. In other words, understanding how it's designed, whether you use that section or not. They sometimes use, you're going to see anatomy based in here. You're also going to see how they what's the word I want? Nomenclature, how nomenclature works. So with that thought in mind, we're going to stop at 28289 and 28291 first. This is called hallux rigidus. And hallux rigidus is not really a bunion procedure. Sometimes we lump it with bunions. It's called the poor arthritic toe procedure, and there's a good diagram on your screen right there. It shows a red inflamed toe. Hallux rigidus is very painful, and it's commonly associated right there at the base of the toe where the metatarsal, your foot bones, meet your toe bones, the phalangeal joint. We have a revised code and a new code with this. And then I'm going to notice a couple things too. Does it show up on this one? Yeah, those little bitty knobs on each of the toes. You see they're kind of muted. Those are the cephalmoid bones, and those are included in the codes, and for both this one as well as the bunionectomy procedures. So let's look a little closer at the change and how you differentiate between these two arthritic toe conditions. The first one that kind of reworks the 28289, it's the cleanup, it's the debridement. Remove those bone spurs. But if they put an implant, then we have a new code. Makes sense. It's more difficult procedure, more intensive. So 28291 is brand new, and it's for putting an implant after they clean up that poor arthritic toe. Now we're going to switch to the actual bunion procedures, hallux valgus. And the bunion procedures, I'm surprised to see this year revised. And here's a good picture of a bunion. Look where it is right there on your big toe, hallux. Right there where the foot bone meets the toe bone is the problem. And there's various degrees of corrections that are needed depending on what the deformity is all about. So let's start with a little bit about the foot anatomy. Oh, wait a minute, let me go back. There's something I wanted to talk to. If you have codes 28292, 28299 in front of you, the first thing you're going to see, if you're familiar with these codes, is they no longer have a reference to eponyms. Eponyms such as McBride or Aiken procedure, Keller procedure. So I was wondering, why are they changing these? Why did they go to more of an anatomic structure? Well, according to the CPT's Insider's Guide this year, they said that they want to get away from having eponyms, because if the doctor would say, I'm doing a modified McBride, what the heck does that mean? Or they want to get away from coding just a word. They want you to code what's being done, not what the eponym says. So I think that's a good move. Oddly enough, the alphabetic index still does this year, in 2017, reference those particular eponyms. So they're still there, just not embedded within the code description. Okay, first of all, let's look at these codes. A glance at the code procedures for bunionectomies, you're going to see some anatomical markers. They're going to talk about, oh, we had to do a wedge resection at the proximal phalanx. Look at the circle there, right? And this is an odd picture, I know, but I kind of like it. The first metatarsal right beneath the yellow circled phalange, that's your foot bone, and that's usually right there where the foot meets the toe is where it starts, the deformity starts. When I'm reading an op report, and some of these op reports are very detailed, I have to use a diagram to see where are they working. And they'll talk about proximal this and distal that, and it doesn't take long for me to get confused. That's why I use these diagrams that I pulled off the internet to help make instructional guides for students, but for myself as well. Let me show you what I mean about the maze of distal versus proximal. Look at this diagram. If the doctor says he's working on the proximal phalanx, that's the green part. If he's doing an osteotomy, that's not the proximal metatarsal. We have proximal means closest to your body. Distal anatomically means further away. So the very tip of your big toe is as far as it goes, and that's the distal phalanx. That's the toe. If they're making an incision in the distal metatarsal, that's right there where that beige meets the green. So again, this is another diagram that helps me when I sort through those feet procedures, which are not my favorite. I find that it's a skill all in its own. Notice the purplish color, those are the ankle bones, and then we go to the metatarsal. Notice we do not have a blue for the big toe. That's the middle phalanx. There's no room for that little devil. Here's a nice picture. Every code, if you want to start with 28292, and this is a common type of organization for a nomenclature, a naming system, which is what CPT is. 28292 is the most simplest form of a bunionectomy, and what they'll describe is right there where the foot metatarsal meets the phalanx is what they call the medial eminence, and they'll shave that off. You'll read that they'll bring the cutter out and actually cut that off. That bunion is, people allow anything to happen if your feet hurt. They bring this all out. There's soft tissue damage that's happening, and the patient's already in a lot of pain. And what happens is the toe starts getting out of alignment. Then shoes become, you can't even wear shoes. Sometimes the difficulty of how bad this is how the codes are lined up. So we're going to look at that theme in a second. Let's look at another drawing. This one is an x-ray side by side. And there's that on the left-hand side, those little sesamoid bones. People want to do something special with that, but it's all inclusive. I think this is funny. They either misspelled metatarsal on the slide or probably another line, if it's Australia or English, I don't know. But you'll see this one looks kind of minor from the x-ray. The deviation's not too bad. Some of the other pictures, if you want to get grossed out, you can go on Google and look at images, and yeah, it can be really, really nasty. The whole point is they want to shave off that medial eminence right there where the metatarsal meets the phalanx, and then do the correction, and that correction is what drives the coding decision. How much are they going to have to take off of what bone in order to align it? This is a moving picture. It's pretty cute, but it gets on your nerves after a while. But you'll see that they cut off, that's that bottom picture, they'll cut off the medial eminence, and then this is a wedge resection or osteotomy of the proximal phalanx. Now this all leads to the codes. Let's look at this. Let's look at the code selection. Here we go. Proximal phalanx. And this, oh, by the way, couple points. I'm driving the folks at Walter crazy. I tweaked my slides this morning, nothing major. You'll be fine. When I was practicing and looking over my slides, I thought, I really should put the codes on there. The last group didn't get that benefit, but you get the codes. It saves you some writing. You don't have this slide. You've got the blue, the red, and the green, but if you would write the codes to match the description, the proximal metatarsal osteotomy, if you have the book in front of you, that helps too, 28295. So they're taking a piece of what you saw on the last slide of the proximal end of the oh no, you didn't see it. Wait a second. Hold on. We're going to go back. They're taking a piece of the right there, the proximal phalanx. So we're going to go down there. That's that second to the last code. This is taking a piece of the foot metatarsal, which is beige on your screen on the right-hand side. If they're into the distal metatarsal area and taking a piece of the bone 28296, that's at the top part of the beige bone. The middle one, the green one, is the odd guy out. That's for fusion, joint arthrodesis, and that documentation will be real clear. They're going to have to fuse the bones in the foot. And then the proximal phalanx, which is what you saw on that last moving slide, 28298. We are now into the green portion of the toe. And then double osteotomy, which is the worst case scenario, is where they're doing multiple wedge resections of the toe. Okay, so if you have this in front of you, if you don't have your code book, if you prefer to use your code book, we're entering into a quiz. I've talked too long. It's time for you to do some work. And guess what we're going to do? We're going to do feet. Are you ready, Mary? There she goes. So you have the codes in front of you to differentiate. All of them have removal of a medial MS, so that's not a decision maker. But what would be the correct code for proximal metatarsal osteotomy of the bunions? Oh gosh, we got actually arranged this time. Not so much, I'm giving you a few seconds as I look at the poll numbers. And I will go through each option and tell you what's right or wrong so you can feel confident. Okay, it looks like it's stabilized. 64% chose option B, 28295, and that is the correct code. The first one, 28292, option A, about 11% chose that, and that's a simple medial eminence. That's where they chop off that hump that's hanging out. That didn't include the proximal metatarsal, which we described there. C, what's wrong with C? Let's see, 13% chose 28296. What's wrong with that one? It's a distal metatarsal osteotomy, not proximal. So I told you that distal and proximal is a pain. If you're a speed reader, which we have to be sometimes in coding because of the long op reports, that can be a struggle. And then the last one, we had 6% chose 28298, and that one is proximal phalanx. That was the toe, not the foot. So yeah, you can see how the wording on this one can cause some struggles. Not easy stuff. Those who code those every day get really good at it. The rest of us struggle. There we go. Okay, now we're going to switch. You can take a deep breath because respiratory is a little easier. There's only two major areas that receive some changes, and that's laryngoscopies and the plastic codes. First, I want to stop at laryngoscopy codes, and this is a summary slide. According to AMA, the reason they changed this year, the family of codes, is they felt it was misvalued and need to be revised. So you're going to see some new codes dealing with laser. You'll see the word fiber optic removed. It just says flexible laryngoscopy now. And then you have a couple new injection codes. Now, you do not have the next slide. Do not panic. It's just my way of focusing in on what is new. So if you have your codes in front of you, I think these are out of order. That's another thing that drives me crazy. Yeah, these are a little bit out of order. But these are the three codes, and I've not listed the entire description, but I wanted you to see how they have decided to differentiate what is already there versus what needs to be new. So we have a new ablation destruction leisure code. And we have 2 new codes for injections. One is just therapeutic injections, such as a steroid for severe inflammation. And the next one is what they call an augmentation. You'll see them use filler substances to help when the vocal cords just aren't acting right. So that's all for that section. Now we're going to move to the plasties. And the new revised codes in this section, starting with 31580, 31592, have been expanded greatly. They've added age as a determining factor for treatment of laryngeal stenosis. And of course, here's a quick anatomy lesson. I always love these. You have the tube-shaped organ of the neck that contains the vocal cords, and it connects to the throat, which is the pharynx, and the trachea, the windpipe. And one of the new codes, 31592, the last on that list, talks about cricotracheal resection, which is right there where the larynx meets the trachea. So there's how that all works. Let's look a little closer at the decision-making of those laryngoplasty codes. The breakdown is, in this code section for the laryngeal stenosis, is the age of the patient, which I mentioned, and whether they inserted the indwelling stent or not. And that's why this left-hand side of the screen is one decision-making, and then the age is embedded in all of those. You know what I found interesting is that there's a note there that says removal of the indwelling stent is an unlisted code, 31599. So you can put it in, but there's not a specific code for taking it out if they're using unlisted code. Righty then. The next one, this is a new code for medialization during a laryngoplasty. This is where a patient has paralyzed or scarred vocal cords, and they like to push those weak vocal cords closer to the opposite vocal cords to make it stronger. That's the word medialization. That one makes sense. Now the next one that has the most changes, cardiovascular system. So take a deep breath. We have quite a few new codes, revised codes, extensive changes, and we have a new phrase in our vocabulary this year called dialysis circuit. Now, we're going to have to do a little bit of a review here before I reveal the new codes. One of them is differentiating between an AV graft and AV fistula, which happens to be one of my sticky points. And it does lead into what's new with the dialysis circuits codes. And if you want to turn to 36901, I'm getting ready to discuss those. But before I do, we're going to have an overarching look at why patients have fistulas and grafts and what they do when they misbehave. First of all, dialysis. The goal of dialysis, is, most of you know, is to remove waste. Your body isn't doing that work anymore. Most of those patients have some sort of form of renal failure. And they remove the waste and excess water when the kidneys can no longer do that job. And you'll often see patients having to have these visuals for hemodialysis to assist with removing the blood from the vein and filtering it back after it's cleansed. Now you'll see, you can forget the top part, I think it's interesting, but look at the arm there, the blue and the red. This is where they're poking the vein. That's an important part. What you're looking at there is an illustration of a direct anastomosis, and they're creating an AV fistula. Now, why do they do that? Well, anatomy of the arteries kind of tells you why they need to do it. Do you see how the vein is thin? The repeated pokes of the vein, the patient couldn't handle it. It's not strong enough. Its arteries have a more thick, elastic, muscular walls, but the veins are not so much. They're non-elastic, and they have a low pressure. So what happens is when they do a hemodialysis, when they connect, make that fistula, essentially they're connecting the vein to the artery to give it strength. We like to talk about it going to the gym. The artery gives that vein strength so that it can handle the repeated sticks needed for dialysis. And here's code 3, it's very similar, common procedure, 36821, direct anastomosis. This is where they physically take the vein and the artery and make an anastomosis, put it together. Now, the only downside to this is it's preference by most physicians, obviously, because it's your own body. It consists of your patient's own tissue. It resists clots. It resists infections. The only problem is it needs to be matured, and sometimes the patient can't wait that long for that to become matured. So when that happens, then we can't wait for an AV fistula. We have to go to the store and get a piece of tubing and create what we call an AV graft. And if you look at the screen here, you can see that tubing that does connect the vein to the artery, but using this artificial type of arteriovenous graft. And this is where a lot of coding professionals struggle with this, because I think it's doctors use the words interchangeably. Number one, they'll say AV graft, and the next sentence they'll say AV fistula. That's why you have to look at the details within the operative report. The other thing is what CPT kind of does to us. If you look at the codes beginning 36825 and 30, the description at the top calls AV grafts AV fistulas, and that's always confused me. So that's on my wish list, as I wish they would fix that at some future point, because people, but if the codes differentiate between grafts and fistulas, then we need to have it very clear in our nomenclature. So what has changed and what has not changed? Well, we're going to talk about that right now. The dialysis circuit, for fixing the dialysis circuit, say removing a thrombus for open procedures, has not changed. This is the same, 36831 and 36833 for the graft versus fistula. These are not revision codes. This is just straight up thrombectomies. These have not changed, but what you're going to see underneath there is an exclusion note saying, if this was performed percutaneous transluminal mechanical thrombectomy, you are on the wrong section. You need to go to the new section called dialysis circuit. Now, what is a dialysis circuit? Well, they're talking about when they create the AV graft or AV fistula, and typically in the arm, that's where they do it, but there also could be problems down the road in the central part. And so you're going to see some terminology we've never had to worry about before with this. Is it a peripheral or central problem? And anatomical structures are real important in this. You'll see, well, here I'm getting ready to click to do a more extensive review right now. Hold on a second. There it is. If you have those codes in front of you, it's just more meaningful. Let's do it. Here we go. Decision making between these codes. First of all, are you in a dialysis circuit? That means the patient has problems with their anastomosis or graft. Next, was it performed? You shouldn't even be in this section if it's not a dialysis circuit, and you shouldn't even be in this section if it's percutaneous transluminal. Those open codes I showed on the previous slide. Now, once you decide, yep, I'm in the dialysis circuit, you're going to have to ask, okay, am I just doing an angiogram, or am I doing some sort of intervention? That's how the codes are differentiated. And are you working on a peripheral or central segment of the dialysis circuit? So we're going to take this apart. First, what's peripheral versus central? And guess where we're going again? Anatomy. On the left-hand side, peripheral typically means arms and legs. But when does it turn into central is what we have to worry about. And luckily, CPT did a good job in the very long note that appears before these codes that differentiates between what's peripheral and central with anatomical markers. But essentially, peripheral is the arm. Now, eventually, the arm's going to go into the central part of the body up there at the top when it says subclavian. Same way with the leg, the common femoral vein, all of those. If they're working in the leg on the right-hand side, essentially, if it goes into the iliac, then you're in the central. And I've got that for you on another slide. So here's the arm part. You saw the arm on the last screen. But if you get into the subclavian vein, any of those regions around the moving past the cephalic vein, then you are now in the central segment, and that's going to change our code assignment. Subclavian is a good example, and innominate veins are a good example, all the way through the superior vena cava. And then this is how it looks for the leg. In the lower extremity, the central dialis segment includes such veins that are central to the common femoral vein, moving away from the common femoral veins such as the external iliac, common iliacs. So, to recap, the common femoral vein is considered peripheral. The common iliac veins are central. So if the focus of the physician's work excuse me, is central, the anatomical markers have to be there. Okay, we've done enough anatomy work. Let's look at the codes and what it means this year. Starting with 36901. You can see that CPTs continued to bundle a lot of the procedures that are normally performed together. They've done a data analysis, and they started doing that a while ago. And so all the introduction of needles, catheters, imaging, all of these radiological support for this code is embedded into 901. Now, if they do intervention, this is just the look, no intervention, then there it is at the top in red. That's the look. We're still in peripheral, that's why I put it on the slide there. But notice there's two codes there. One is, okay, we found some problems in the angiography, and now we have to do a balloon angioplasty, and that's 36902. All the work that's done in 901 is embedded in 902. You'll notice how CPT always does that with the use of the semicolon, telling you everything that's above this includes this. And then they say, oh gosh, this patient needs a stent, then that would be 36903, and everything's included in that as well. So that's the first three codes. Now what happens if they have a thrombus? Starting with code 36904 are the thrombectomy codes for the dialysis circuit, and that's important to ground yourself every time we talk about that. And this is percutaneous transluminal, not open, because that would be those other codes. Now, coders are directed, there are notes that will direct you to the open codes if you look at it. But look carefully at this code. There's a trick to this. Does it say, you'll notice in the previous codes we said it was peripheral. But what about this one? Interesting enough, they just say dialysis circuit. So we don't care where the thrombus is if they do a thrombectomy. This is your one-stop shopping, I believe, for all the thrombectomy codes. It was a little bit of a surprise to me. I had to look at these codes for quite a while. Continuing on, let's look at breaking down the thrombectomy codes. Again, I put this slide together so you can see the relationship. Plain old 904 is for thrombectomy. Indented underneath there is angioplasty, but they're real clear in their notes underneath each of these codes. You can't use this one with this one, meaning 904, if they do an angioplasty and a thrombectomy, 905, let me open that up with you. You'll see that 905 says do not report 905 with 904, which means all, and again, the use of the semicolon tells me everything's wrapped into that. Same way with 906, all the interventions above, plus in this one we have a stent. Very interesting. We spent a lot of time on this one, you can tell. And we have three add-on codes, not just like them. We have the 36907, 908, and 909. First, you'll notice that these are central dialysis segments. So if they do an angioplasty or do a stent on the central side, then these are your codes. I put this next slide together because I didn't do it in the last presentation. I want to make sure that you all understood. 909 is separate. It's a failed hemodialysis where they have to shut it down, either using embolization or occlusion. So that's more of an odd guy out, but it's still part of that dialysis circuit. All right, are you ready for a quiz? Because you knew it was coming. Here we go. Leave your book open to those codes, those 36901 to 36909, and we've got another quiz, and this is where Mary's going to help us out. Patient is seen for a malfunctioning hemodialysis fistula. And this is done, you know, I removed it from there. Good documentation. What documentation is missing for this? Well, it's done percutaneous transluminal. Well, I do want you to be in the 36901 codes. So angiography is performed, and during the angiography they go, oh my Lord, we have to do an angioplasty. What would be the correct code? So again, let's put this in the dialysis circuit. It is performed not open. Okay, let's see how we're doing. So you guys, I can't fool you too much on this one. All right, it looks as though the winner, and which is correct, is code B. 36902 is the correct code. If you chose A, 36901, 2% chose that, and that's just no intervention. That's just looking. That's coding the first part of this, the angiography part. The third choice, 36907, is central. Tried to fool you there. This is done in the arm. And I probably cut that part out, but it is done in the arm. And the last one, what's wrong with D? I had 9% choose that, and you have to be real careful. Those codes can't be used with one another. It's the work of the angiogram is included in the angioplasty code, and that's why 36902 is the only code you need that. Your software would probably help you, again, with the ins and outs of what you can code together and you can't code. All right. I am going to go back to the presentation and switch away from dialysis circuit. Aren't you happy? There was a whole bunch of codes with those. And now we're not quite done with we did this one. We're not quite done with intervention, but we're moving on to some more new codes, not dialysis circuits, some other ones that they've changed. And we're going to look at how they're organizing the transluminal balloon angioplasty. Let's review the extent of the procedure first. Usually they open it up. They use a balloon and open it up. But depending on how much plaque, sometimes a stent is needed. Now, if you open your book to the codes, starting with 37246, you might be asking yourself during the description, oh my gosh, they listed this laundry list of what's excluded. Well, then what's included? Well, first of all, let's look at this very closely. This is all arteries. 37246 and 347 are both treatment of arteries. The dialysis circuit's not here. We just left that a few seconds ago, 36901 series. Lower extremities for occlusive disease, not here. In fact, if you turn your page back, 37220 has that range. What's also not here? Intracranial arteries, coronary, pulmonary. So you may be asking yourself, and this is a slide I added at the last hour, so you do not have it, but I just felt like I needed to anchor our discussion. Then what in the heck is included in these codes of the arteries, this intervention, the balloon angioplasty? Well, arms would be included here. Axillary would be included here. And then I backed away and said, well, pretty much anything in the central part of the body that's not intracranial, not coronary, not pulmonary. So you think things like gastric artery, renal, subclavian. So and again, this diagram will help you with that. So now's a good time to say, again, I don't have the ins and outs of everything that can be reported together. We have to read those notes. You know, this is all new to all of us. And if this is your bread and butter, this is something you do every day, then yeah, you're going to have to read very carefully to get comfortable with it. You'll see commonly that they'll add all the imaging, the radiological portion is included in these codes. That's not new. They just keep adding it. You'll notice something here is there's nothing to do with veins here. That's the next code, 37248 and 49 for the add-on codes. This is for the balloon angioplasty of the veins. And this is much easier. It's all the veins except those in the dialysis circuit. So it's not like the last section. Ready for another quiz? Hopefully you have your book open to the 3723846, and here we go. My buddy Mary's still out there. The surgeon performed should be an angioplasty of the superior vena cava. What is the correct CPT code? And there's 3 choices there. 370. I mean, these are out of order, so they're just how it works with CPT. Some of these are just not in order anymore. 37238 is the first one, 46, and then 37248. Ooh, this one's a little closer than in the past. I always get excited. You know, I make these questions up, and I want some sort of controversy to make it interesting. And it looks like they've stabilized. Okay, let's look at these. The correct answer is C, 37248. And oh, shit, oh, no, that's funny. People change their answer. Quit changing. 48%. When I looked at it, chose that one. The next one that was closest was B, and that had 37%, and that's 37246. And what's wrong with that one? That one's for arteries, not veins. One was a technical reading question. We said this was vena cava, so it had to be C. And what's wrong with the first one? That one got the least amount of votes. 37238 said a stent was inserted, and we didn't have a stent. These codes have lots of descriptions. I highlight keywords. I write notes to myself in the margins in order to help differentiate because it is difficult reading. Okay, good. Thanks for participating. This is the slide that says you're almost done. You've been with me about an hour. We're going to do very shortly, I'm going to show you it's kind of a survey of everything else being done. We're going to stop along the way and look at what's new and exciting. Then I'm going to turn the podium over to my buddy Ray Allen, who's going to show you some exciting things that Walters School can offer you. Okay, laparoscopic procedures is our next stop. I'm froze. Oh no. Hold on. I'll have to start it all over again. Every now and then technology hits you with a loop. Okay, let's see if this one works. Yay! Okay, a couple new laparoscopic codes, and I was really surprised there weren't more. I'm always disturbed when I have to give an unlisted code for a lap code that's been around a long time. But we have a couple new ones. We have to be excited with what we got. 43284 is a new one that is in the digestive system chapter. It's a very specific code where they're putting a placement of a augmentation device. And there's an example I got. It's called the Link system. I stole this from the manufacturer's website. It's being used for GERDs, patients that have gastroesophageal reflux disease. So it's a new type of, and it's very specific. So you'll know when you have that one. The next one is in the female reproductive genitalia area. We have a new code for laparoscopic ablation of uterine fibroids. The last couple years, it's been in the Category 3 codes. It was 0336T if you're taking that down. But it's now a Category 1 code. We currently have codes for resecting fibroids, but not destroying fibroids. So that's another perk to write yourself a note about that. And also look at the excludes. You can't report this code with a lot of the other CPT codes, such as laparoscopic hysterectomies. Now, just when you thought we were done with spines, oh no, we are going to look one last time at spines, I promise. The spinal injection codes, we have new ones. They've deleted the 62310 series. If you deal with these all the time, you know what I'm talking about. They reworded it, regrouped it, wiped it off, and merged as new codes. Now let's, again, I can't say how important it is to read the notes. There are a series of codes all pertain that we're going to look at into interlaminar epidural or subarachnoid placement. I have a new slide that you do not have, sorry, but it was a last-minute addition, probably about an hour ago before I started. This is just to show you, I cut and pasted this, and I did not want to put it in your handout because I'm going to get sued one day for using people's, Mayfield Clinic's going to sue me for using, I shouldn't say that, I'm being recorded. Okay, here on the left-hand side is a look at what they do when they do an injection into interlaminar epidural. And what they do is they put that needle right there in the epidural space through the lamina. That's how it gets its name. The subarachnoid, just like you see there, and this is from Mayfield Clinic, shows you they're putting the needle in the subarachnoid space. I think it's important to have those visualizations to see it's a different skill, I suspect, is the reason they're differentiating these codes. Now you're going to look at the decision maker's anatomy. You just saw that. Another decision maker is whether imaging was used or not. And then the last one is if it was an indwelling catheter, not just a straight injection. So if you have those codes in front of you, the 623, we've got our last in our poll question. So let's brush off your coding skills and see how you do. Time to challenge yourself. Mary's on it. You can feel her. There she goes. Patient required a cervical interlaminar epidural injection under fluoroscopic guidance. And you have 4 choices starting with 62320. This is where I have my fun. Okay, let's see. I'm going to write it down now so I don't. Interesting. The majority of, we are now getting ready to close this out. I'll give you a few more seconds. I know it's a lot of reading sometimes to process. Okay, I think I'm ready. The correct code in 50% of the audience. Thanks for participating, by the way. I appreciate it. And you're correct. B is the choice. 62321 is the correct choice. The next highest was C. Option C was incorrect. 22% chose it, and that was lumbar sacral. So you missed the cervical piece to this. It was the anatomical location. The first one had only had 19%. 62320 is not correct because imaging was not included in that code, and I said under fluoroscopic guidance. That was a tricky one. And then the last one, D, had 7%. And what's wrong with 62324? It says indwelling, and there's no documentation that this was an indwelling type of catheter injection. So good job. You know what's funny is I'm looking at the last time I did this, and it's very close to the exact same results from the last time. That's 2,000 people that are consistent on that one. There's some sort of interest in there. Okay, we did the survey. Now the next section of this, I'm going to stop for a second, and then we're going to have a demonstration by Ray Allen, who's going to take over the screen, and then I'll pick up with our survey of the last of the sections of changes this year. So Ray Allen, are you ready?
I sure am. How's my audio?
Your audio is great.
Great. Okay, let me just make sure I'm sharing. And can you see my screen? Are you able to see my screen?
I can, Ray Allen.
Okay, perfect. You can see that I was actually following up on one of the questions that one of the folks was putting in the panel about some G codes. We'll correspond by email afterwards. Let me show you the Audit and Revenue Resource Center, which is the tool that I use to keep up with annual changes, but then also just to do CPT code research, generally speaking anyway. And a lot of folks on the phone are MediReg coding suite users, so I just want to use a little bit of time to show you where you can get to the 2017 pre-release information so that you can pull up these changes and take a look for yourself. So the first thing is you get your daily email alert every day, and the presentation slides are in there, so if you want to download the PDFs from today. We did repost the 2017 OPPS changes as well. They sort of go hand in hand. Now, normally when you go on the left-hand side under Codebooks and Guidance and you click on the electronic procedure codebook, you get taken to the current year book, which is fantastic because it's still 2016. But I know you want to get a head start on the 2017 information. So just go to the link that says Guidance for Coders and scroll down in that library a little bit, and you'll see the pre-release version. We have the pre-release version for the physician's fee schedule out already, and we're working on the pre-release version for the procedure book. And what you'll notice about this book is that every week we've added a couple more things. Right now we're QAing the HCPCS changes, so all the alphanumeric codes, and the CPT changes are already out. So here's the updates and changes report. That appears in your daily email alert, and it will summarize what's been added, modified, and deleted in the book. And then you actually have full browsable access to the entire book. So during your conversation, I've been seeing questions come in, and sometimes I just need to go look at the descriptor for that particular book or code, or I need to look at the parenthetical guidelines, and the answers that you're asking are actually pretty accessible, in a 30-second query. The other thing I want to point out is that we have loaded the CPT changes Insider's View for 2017. In the MediRegs platform, that's a searchable tool. So if I search for 2017, you're able to see what content has been posted related to that, and you can get into those changes and really start to take a look around. I know one of the questions that was put in the panel was related to the telemedicine codes. So, here is Appendix P from the CPT Changes with a description of the difference between modifier 95 and when you would use the HCPCS modifier instead. So, very useful to have that information so easily accessible. Now, when we post this new content, you don't really need to go fishing around or doing any installs. Just watch your daily email alert, and that updates and changes report will appear in there for you, and you'll know that that content is ready. A couple other places where I see a lot of changes being posted is in the CMS transmittal, and we've created this nice database of all the Medicare MLN matters, job aids, special editions, and transmittal. And I spend a lot of time in here just as an indication. Let's just look and see what CMS posted so far regarding January 2017 updates. Quite a lot of them I'm expecting. And you can see, whether it's a zip file or the actual transmittal, what updates are coming out. And so you can really sort of stay right on top of that information as it's posted. And I did hear from one person asking questions about changes to the clinical lab fee schedule and whether or not there were some G codes deleted. My read right now is that they're deleted from the lab fee schedule, but not deleted in general. But we can take a careful look at that. The lookup and payment tools that are included in MediRegs are updated automatically, and we're working on those updates for 2017 as well. And then I really just want to take a look at, let me steal for just a second, I want to pull up one of those codes that we were discussing. I just want to take a quick look at some codes in Code Explorer. This is a typical research workflow for me. If I don't know my code, I can use a keyword to quickly identify a code. If I know my code, I can just enter it in the box, and you can put multiple codes in the search box. And this tool is designed to sort of start with what you know and get you answers very quickly, whether those answers are coding, coverage-related information, so what local coverage determinations might be available, payment information coming directly from our two calculators, which you can set for your geographic region, and the guidance library. So, just as an example, this replacement of a mitral valve code, I can quickly dip into the code book where I will see any of the information that I would normally see in my paper book. So the chapter guidelines, the section notes, so those instructional materials that typically precede a code in your paper book, as well as the parenthetical guidelines that follow that code in the paper code book. So I noticed somebody was mentioning that, Gail, you keep asking us to take some quizzes and take out our book, and some people don't have their book yet. Well, I do. I'm online, and so I've been keeping up with your quizzes by just doing a quick search inside the title and not having any trouble finding what I'm looking for. We have done a couple of enhancements to this book that really make coding edits a little bit easier to understand. We've got the consumer and clinician-friendly descriptors built in. And then you'll also notice this cool thing that we've done. If you open your book to 33430, there's no parenthetical notes after it. It just doesn't have any parenthetical guides. But other codes in your paper book do have notes that would relate to 33430. So we put those on the same page. We call those reverse parentheticals. And then also we include the payment information when you tunnel into the book. So I'm showing 2016 information because that's the current one, but I could go into the 2017 as well. So I can very quickly look at the code and its status indicators and understand whether it's payable and what that national unadjusted payment information would look like. And then I can pop back into the calculator if I want to set that up for a geographic location. So very quickly, not to do a whole demo, but just to help folks who have the coding suite know where they want to go to get to their 2017 information, and a little sample workflow. The last thing I want to point out is if you have the coding suite, you also have the coding comply tool. And although I really appreciate reading Appendix D and taking a look at study guides like this, sometimes I just want an Excel file. And so I appreciate that I can use coding comply to come in and pull a report. So if I wanted a listing of all the added and deleted CPT codes for this January, I just run the report like this. And this is kind of like a backdoor into our coding tools. And there they are right there on screen with the long description and whether they've been added or deleted, and I can just click up here to export that as a CSV file. So if you don't know where to get to all of this and I just went too fast and you're a MediReg subscriber, please just reach out on the Welcome tab. You can click the support link right here, and we'll set up a free training for you to make sure you know how to flow through. And if you're not a MediReg subscriber and you'd like to take a peek, by all means, let us know, and we'll be happy to set up a quick 20 or 30-minute web call so that you can see if this would be useful in your workflow. So I think that was fast, but I think I covered what I needed to cover, and I'm going to go ahead and make you back to being the presenter, Gail.
Thanks, Ray Allen. I think that I'm always impressed to see all the plethora of resources that Wolters Kluwer offered, and training professionals are only as good as what resources they can get their hands on to get answers. So that's good news. Okay, back to what's new. And oh, did you going to say something?
Nope, it's all you.
Okay. Thank you, dear. Let's go back to what is new and exciting. I'm going to start with radiology. Not a lot of changes. Again, if this is your area you're responsible for, Appendix B is your friend. It has an entire list of everything that is new and exciting in radiology. I just went through myself and chose some things I thought were interesting. Let me go through those with you on this summary slide. The first is the continuing the theme of bundling radiological services. They've been doing this for years, and you saw that in an example when we did the angiography when we were in the dialysis circuit codes. So it eliminates the need for separate codes for radiological portion of the procedure. There is a new code for ultrasound of the abdominal aorta for an abdominal aortic aneurysm, that's 76706. And then mammography had quite a shift this year, and I thought that that's something we could look at on the screen on the side-by-side. And you do have this slide. Between 16 and 17, you can see that the driver for computer-aided detection is no longer a decision maker. It's just, in 17, is it diagnostic or is it screening? And it's fine if it's including computer-aided, and it's also fine if it's not. So that was a shift. Pathology and laboratory, I wasn't going to spend much time. I just put a summary slide together. I had a typo the last time. I think I fixed it, but forgive me if there's a typo in here. But this is a nice summary. If this is your area to fix, either through your workplace, then go through the Appendix B and pick the ones that are really important for you. I've shortened the descriptions, and it's not a long laundry list this year, I was happy to see. Medicine, we already looked at this a little bit with conscious sedation, but I wanted to also stop along the way and show some of the interesting shifts I've seen with how they are describing some of the services. The first is influenza virus vaccination codes, and it's there for you on the screen. And I've highlighted in red what the differences is between previous editions and our new 2017. They've eliminated the reference to age and went to dosage. I don't know off the top of my head why, but this is a good one to look up in the Insider's Guide. The Insider's Guide that Ray Allen mentioned earlier, that is published along with CPT and revealed at the symposium in November, they give a rationale. And earlier I said in my presentation, most of the rationale is always, I've looked at the data, it was inconsistent, or it's been misvalued. So some of this is cleanup, and they don't give you an exact reason. But here's another interesting one. In psychotherapy codes, they eliminated the family member component, and they're just basing it on time for code 90832. And then this is another one for without the patient present business, but here they've added time. That's right, this is the 90846, where they've added time as a determining factor for putting codes. Now I've seen new codes. Oh, I don't have it on the slide. So let's go to 96160, 96161. New codes have been added to the health and behavioral assessment intervention section. They have identified, let's see if I have it on the next slide. Nope, I don't. What they've done with this is they have both administration or of an assessment for this for this type of intervention, but the big decision maker is whether it's patient-focused or from caregiver-focused. And again, that's 96160 if this is based on time, face-to-face, initial time, subsequent time. So this, I think they're self-explanatory. I just thought that they were interesting. Physical therapy, occupational therapy, and athletic training codes have changed. They've been expanded. There is more detailed criteria. The model, to me, looks a lot like an evaluation and management codes. They have history, they have examination, they talk about body systems, and very much modeled after E&M. And for the level is on the screen here in blue. You see low complexity, moderate complexity, high complexity, again, E&M terminology. And then there's a code for reevaluation of the plan. So this section has been changed pretty extensively. Now we're going to go on to Category 2 and Category 3 codes. Category 2 codes were gentle on us this year. They have one little change. 4151 code was changed, and it's underlined the key changes. So if you're responsible for performance measures, that's it right there. It's an easy one. Category 3, by the nature of it, will always change because this is the emerging technology sections. And as you saw earlier, some of the codes, like the laparoscopic ablation of fibroids codes, have been sitting in the emerging technology section for a while, and then after so long period of time, they make decisions on whether to give them a real CPT code or sunset them. So as you scan through this, you're always going to see new codes. And what I would suggest you do is which ones I would look through. It doesn't take long to scan through. Look through the ones that your provider or your hospital performs, and then warm up to those descriptions because they might be around for a while and they might turn into the regular Category 1 codes in CPT. What I did for fun, I went through and thought, oh, let's just see what's new and that's fun for me to look at. I saw a collection of codes for insertion, replacing, removing, programming, cardiac modular system, starting with 0408T. This is kind of a new investigative method for treating patients that have congestive heart failure, either moderate or severe. And it delivers impulses that corrects the patient's CHF. That's the extent of my knowledge about this, but my point is there are good YouTube videos out there, and that's what this screenshot is. It's a 2-minute video that explains the entire process. If this is something that your facility is doing or your provider is doing, go ahead and educate yourself 2 seconds, and it just makes it more meaningful. And of course, they're following the same schema they do with all of the types of systems, such as pacemakers and such, defibs, inputting it in, fixing it, taking it out. The next one I thought was interesting is a 0421P, a water jet ablation for benign prostatic obstructive tissue. I saw that on the internet there was some trials going on about the use of this. It's kind of a high-powered surgical piece of equipment that helps destroy tissue. It's supposed to be kinder and gentler to the patient. And then the last one, they call it phrenic nerve stimulation system. And the reason this one caught my attention is for sleep apnea. It seems like everybody I know talks about sleep apnea. So this is a series of codes that, again, inserting, replacing, removing, programming. It's type of neurostimulator system where the leads are placed around the phrenic nerves and are attached to a generator that's in a subcutaneous pocket in your chest. And these nerves help control the movement of the diaphragm. So it helps with the airflow into and from the lungs. And supposedly is another alternative treatment for sleep apnea. Okay, my time is getting short, so here's what I'm going to do. I'm going to do a real quick closing statement. I hope you walked away today with some good lessons, something for you to take back to your workplace, make your life easier. I still think that the key to making sense out of CPT is looking for patterns, connecting the anatomy and the clinical picture to help with the codes. I find it more rewarding so you know how the nomenclature works. If this presentation just whetted your appetite to know more, I did develop an online CEU course for Libman Education. Go to their website if you haven't done so. Myself and a couple of my colleagues write blogs. You might be interested in those. They're about all kinds of topics with coding. So go to Libman. If there is a course I developed, a CE course, I think it's worth 3 credit hours, approved through AAPC and AHEMA. It's a slower pace than what I did today. It has more types of interactions, and I think you might enjoy it if you want to know more. Now, one last slide that you did not have that I added because it was generated from questions from the last presentation I did, and that is, where do I find all my pictures and my resources that help with anatomy? And these are my 3 favorites. Blousen, like I mentioned earlier, there's a clip from it. It's free. There are some modules you can get for your iPad that they do charge you for. Sometimes they'll charge like $20 for musculoskeletal or $15 for cardiovascular, one of those. Same way with Visible Body. They have a website, but most of their stuff is purchasable doing apps. It's good for A&P for students, and that's mostly their service line there. And spinehealth.com does a great job, and they are free. Good visuals in that particular one. So I think I have all of like 3 minutes left to say thank you, happy holidays. I appreciate the time we've had here today. I hope you, like I said, had some good key takeaways. And Maria, do you have any closing remarks to the group?
I just want to say thank you, Gail, for a wonderful webinar, and this is our 2nd replay. If anybody's interested in the replay, it can be available at www.mediregs.com. Again, those that are registered attendees, we are happy to send you your CEUs. Please, once we obtain the CEUs, we will send out a survey to you as a registered attendee. Please fill out the survey. We want to know how to better serve you in 2017. And then once you complete the survey, you will obtain your CEUs. Again, I echo Gail. We wish everyone a safe and pleasant holiday season. And this concludes today's webinar. Have a pleasant holiday. Take care.